Brilliant. So thank you so much for joining me, Mr. Vikram Dhar and Mr. Karan Kapoor, two highly revered ENT surgeons, here to talk about head and neck cancer. So, guys, the first question then for both of you, an open question about the first major warning signs for head and neck cancer. What should patients be looking out for?
Go for it, Karen.
Well, I think firstly, you've got to trust yourself. If you're concerned, that's the time to speak to a doctor. But for a head and neck cancer, we talk about sort of an idea of a persistent symptom for more than 3 weeks relating to the head and neck. So either a difficulty swallowing, a difficulty with your voice, a lump that you can feel in your neck. All those sort of things are really kind of important. And if they're persistent and they're there for more than 2 or 3 weeks, that's certainly a sign that I would say you should be speaking to a doctor to assess.
Yeah, I mean, I think it's an interesting thing when people talk about what symptoms are worrying, because if every patient we saw with the worrying symptom had a head and neck cancer, by definition, we'd be missing out on a lot of people. So we have to cast our net wide. And the reality is, perhaps only 3 or 4% of the people that would get referred to as possible cancers, thankfully, those only a small percentage do. And that means that we're capturing everybody. Yes, there are lots of people that will be worried. They might have something. They'll wait for their appointment for a week or two, and then they'll come in. And then thankfully, we can reassure them for 97% of the time, 96% of the time. But it means we're capturing everybody. So I think the message really, I think what Karen's also saying is that trust yourself when things aren't right and get it checked out, because most of the time it will be okay, but we don't want to miss something. Because the crucial thing with all cancers is the earlier you find it, it's the biggest predictor of outcome in all cancers. The earlier you find it, the longer, the better the outcome. So that's a crucial message there, I think. Do you agree, Karen?
I agree with you completely. We use that 3 week thing so we're, to use Mr. Dar's words, casting our web or our net as wide as possible in order to pick up everyone. And it's really quite good when you come to a doctor and you can be reassured.
Absolutely. Very, very interesting, I suppose, to trust your gut instinct, like you said, Mr. Dar there. And then I suppose a major symptom, a neck lump. Would that always indicate a neck cancer necessarily?
Vic, do you want to take us on that?
Yeah, so each symptom has a likelihood of cancer, doesn't it? A neck lump is the hardest of all symptoms, so it's often the most concerning. And certainly if anyone had a persistent neck lump, particularly if it's not painful, particularly if it's not after a cold, because neck lumps, what people are usually talking about are lymph nodes. And lymph nodes are very important in our immune system. They do get big and they do get tender. You all had it when you had a sore throat and felt lumps. But what we're worried about is when they're metastatic lymph nodes, i.e. a head and neck cancer, so tonsil cancer, for example, has spread to a lymph node. And in about 70% of patients that have tonsil cancer, they actually present with a lump in the neck rather than anything inside the mouth. So it's the neck lump that comes about. And there are other types of cancers that present with neck lumps, for example, a lymphoma. And it very much depends which age group you're in about the risk factors. But the other point to take is that even though perhaps 30% of lumps that we get referred to in clinic end up being cancer, most aren't. They just need to be checked out. There's a whole range of benign and sometimes even congenital neck lumps that we need to deal with. And lots of our head and neck practice is dealing with those lumps. But you need experience. The point I was going to make, actually, before we went forward to this, and Karen, I don't know if you agree with this, but I think the more experienced I get, the more I start building up sort of patterns and narratives, sort of stories of what feels right and what's not. Yes, you could assign a percentage to a neck lump or assign a percentage to a sore throat, and that's really useful. And there's lots of work going into machine learning in that and how it could predict what's worrying. But actually, as an experienced doctor, listening to patients, you can often get a very good idea of what's going on. What pattern is a red flag, what pattern is not. And I think every clinician will tell you that. If you ask a detective, a policeman, which of, which animals from the zoo have escaped. Is it a true story or not? Is he just talking about hippopotamus? I don't know. It's very easy for them to pick out which story is one that's to worry about, which one it shouldn't be worried about. If you get that.
Yeah, I mean, I listen to Vic. I think I agree with lots of things he says. It's that thing about, as a patient, you know what you're worried about. You've got a lump. And I think one of the biggest fears that patients have is this something bad? And we all tend to sort of bury our head in the sand sometimes when we're worried about things. So my advice is, more often than not, this is not going to be something concerning. And when it's not, when you know that going in, and we can reassure you that more often than not, it's not going to be concerning, it's a good idea to come in and understand what the process is. And the process is, we're going to come along, we're going to sit, we're going to listen to you, we're going to understand that story of yours, and then we're going to have a feel of your neck and probably send you for a couple of tests, something simple like an ultrasound. And that ultrasound can really help us understand what's going on. And every so often, not just because we're worried, but often we'll say, right, let's do a needle test in order to biopsy this area to be able to reassure you, the patient, about this lump and what the next best step is. And I think what we want you to do is to trust yourself and also know that your concerns are our concerns.
Karan, so I'm a middle-aged bloke, can't I, almost? And I often think, well, it's probably going to be okay. Let me just ignore it. I just don't want to be worrying about it. I don't want to. You've just told me that I've just told you that 96% of people aren't going to have cancer with these sort of worrying symptoms. Then why not? 96%. If I was betting on a horse, I would say a pretty long odds to having anything. If I ignore it, I'm not going to have to worry about it, and it's probably going to be okay. Why shouldn't I go with that narrative?
It's a really interesting thing, isn't it? Because actually, I think the more and more that I talk to patients, they've kind of got this sneaky suspicion. And when you use that word cancer in a room and you say to them, look, I'm doing this to rule out this being a cancer, it sort of breaks an ice, sort of unwritten thing that we do want to say that, I'm going to be part of that 96%. But for that 4%, 3% of people who might have something going on, you said it right at the beginning, come in early. The smaller it is, the easier it is to deal with. The more likely you are that in 5 years' time, we'll say to you, there's nothing, our friendship's over, you're free to go, because that's usually how long we follow people up for. But that 4% of people do need support. They do need help. And when they wait for 3 months, things progress, things get bigger, things get harder to deal with for us as well.
And I think there's a little philosophical point that I often have in my life, is I think you owe it to the unfortunate. So you see a person that comes with advanced head and neck cancer. If you gave them one wish in this world, they would wish that they had come earlier, or it presented earlier, and it was completely curable, and they live forever, or live for their full life. And I think as the 96%, you owe it to them philosophically to come early and to get it checked out, and to make sure we don't end up in this sort of more advanced stage. I think that there's something in that, perhaps. Anyhow, as ever, we're whispering on about that, but it's interesting.
Oh, it's very interesting there, Mr. Dhar, that philosophical point. It's so true. And the discussion we have with ourselves, should I go, should I get checked out, even if it's a slight symptom, it could be the start of something bigger. So it's very important to get checked out, absolutely. And I suppose then it leads us nicely on then to the diagnosis. Then you mentioned there, Mr. Kapoor, about the biopsy performed. Is a biopsy always the first line in terms of diagnosis?
I think the first line of diagnosis is listening. Patients will tell you things. They say, I've had this for going on for the last 3 months and it just wouldn't go away. And listening to them, listening to their symptoms, increased difficulty in swallowing, increased difficulty with their voice, pain that just wouldn't sort of go away, kept on nagging them. And I think that's where diagnosis begins. And depending on what you find, especially if you find a lump, well, we want to know that's what's going on. So then our diagnosis is going to start. We're going to examine you, going to have a look in your mouth, have a look in your nose, often use a little sort of flexible, very small camera down the nose to have a look at the throat, to try and understand where might this lump be originating from. And then we send you for some tests. And depending on what we're thinking about, if we're concerned, if we're not concerned, we will send you for a number of tests. But an ultrasound's a really good starting point. If you've got a lump that you can feel, and often you'll have some imaging, things like CT scans, MRI scans, and we'll send you for sort of specialist tests, including sort of unusual tests, things like a PET scan in certain cases, which is a scan in which we actually inject you with radioactive glucose. But you don't need to worry, you're not going to suddenly turn into the Hulk. This is all very controlled, very thought out, temporary radioactive material that goes in, which is eliminated to the body really quickly, but helps us understand what might be going on, trying to find those hidden things that we sometimes might not even see.
Absolutely, absolutely. A very thorough diagnosis, which is great for patients to know going in. They're going to have a thorough, accurate diagnosis, which is so important. Absolutely.
But I think an important point there, just to sort of lay on top of that, is that we have all these tools, whether it be an MRI scan or just a history or an examination, but they are just moving that line of accuracy of diagnosis, or sensitivity, we call it in statistical terms. So what's the sensitivity of the test? So you want a test that is very sensitive, so it picks up all the cancers that miss anyone, and when if it says it is positive, it is a cancer, then it really is. That's the aim of this test. Yeah. So in reality, I would say that 9 times out of 10, when a patient walks in the room, within the first few minutes, I know just from their demographics, their age, perhaps sometimes their habits, they smoke, they drink, where they may play a role, and the history, they tell us most of the information. So already my test has got a high degree of pickup. And then all these other things, often people say, come in, get me an MRI, that'll tell me I've got cancer. Actually, MRI is not very good for a lot of picking up cancer. I often find that even feeling with my finger can be more useful than an MRI scan to pick up subtle lesions. So it's not so blanket rule that one test will give you an answer. It's to feel and everything put on top of each other, together with our hopeful experience put on top of it, that moves that gauge to a very sensitive, very specific test that gives you an accurate answer. Yeah, sorry, can I just make one more point? Sorry, it's an interesting point, actually. I think these discussions are really interesting because we can go down the sort of more philosophical ideas about things. And I get a lot of people that are health anxious, particularly after COVID, particularly, people, younger men, younger men's a classic group. And they're ruminated about what this might be for hours and hours before they come and see me. I feel really sad about it because they've spent so much time worrying and Googling things which can make things worse. And they want a golden bullet. They want 100% reassurance that this slight symptom is definitely not a cancer. How do you manage that patient, Karan? Because that's a much more common patient than the cancer. But it's equally as important because their lives are being ruined by the idea of a cancer.
Yeah, absolutely.
I'm definitely going to pick up on you on something you said earlier, but how do I pick up with somebody who is concerned, but I don't share those same concerns? It's about building trust, isn't it? It's about building a communication. It's about also saying that your symptoms, I don't deny people's symptoms. You may have pain, you may have discomfort, but what I'm going to do is I'm going to say to you that with the skills that I have currently, with the tests that we have currently, I can't see anything that matches something which is suspicious. It's quite interesting. If you sometimes eat something, you feel like it's stuck at the back of your throat for a second and it goes away. Equally, sometimes people feel like they've got a hair and it gets stuck in the mouth and you can feel this tiny little hair stuck there at the back of the throat and it really, really irritates you. 10, 15 minutes, you might have to have a cup of tea, you might have to drink some water, gargle to get rid of that feeling. When it comes out, some people pick it up and think, that's absolutely tiny. I give you a steak and kidney pie and you hardly chew it and you're able to swallow it. Now, it's about those things. It's about understanding that the body is actually a very sensitive area. And what we as clinicians are doing are trying to match up your symptoms, your concerns, your perceptions to match with what we are concerned about. Now, just because you've got symptoms and we can't find them doesn't mean you don't have symptoms. It just means it doesn't necessarily correlate to something worrying. And I think we've got to be honest as doctors that there is a limit to what one can actually find, and that we don't always have an answer. We are learning as much as you. We're evolving with our symptoms.
You're right. Reassurance is from trust, isn't it? That's a fundamental concept. It's sort of maternal Freudian concept that your fundamental evolvement of trust is from your mother, the person that you have the most sort of close to and you understand. But I would say that there is an element we see a lot in ENT, which comes a lot in cancer clinics, or not cancer clinics, possibly cancer clinics, is this idea of introspective hypervigilance. And I always go on about it. I don't think you'll find it in any textbooks because it's a term I've coined. But in the senses, the throat, the hearing, the nose, smell, patients they certainly don't come to me, but they'd be unlikely to go to doctor, say, doctor, in the tail of my pancreas, I've got a feeling something. You're not going to do that, but you might talk about something in a noise in your ear or a feeling in your throat. And I think patients often will focus on that and get into a slight panic about what it could be. And this just creates in this part of the brain, the amygdala hippocampus, this worry center, I call the worry ladder. It can make it drive up this worry ladder. If we just sit there with our eyes closed and focus on our right little middle finger, we can start feeling actually some tingling there. There's a yoga technique where you go through your body and feel different areas. But if you worry that if you feel that things are bad, things might be a cancer, then you can only heighten your surveillance of that area. It's what I call
picking up on that, actually. What I think is really interesting, if you look at this from a neuroanatomy point of view, the homunculus, the way, the perception of our body within our brain, the head and neck is a huge part of the brain. You think of when you bang your lip, you suddenly think, my God, I'm going to look like Quasimodo. My face is going to be all distorted. You think your lip's absolutely huge. And you look in the mirror and you can hardly see a bump. And that's because your brain has a very large part of its sensory part sort of dedicated to your lips, your mouth, your face, your ears. And that's the reason why symptoms in this area can often be really quite perturbing for people. And I think that we've got to look at the neuroanatomy basis on that. I'm going to go back to something you said earlier.
To look up homunculus. It's really interesting.
Well, you can see what sort of pictures you can conjure up in order to they're there. Now, I'm going to push back on something. You talked about young men. And you said that you could often tell, if a person's likely to be high risk because of their age, their demographic. I was going to ask you about sort of younger people turning up with head and neck cancer, and what your thoughts about the sort of prevalence, the sort of less to do with smoking and drinking, where you sat with that.
Well, so I think what you're coming on to is, so in head and neck cancer, traditionally, when I was sort of growing up as an ENT surgeon, the classic patient was a smoker and a drinker. And that's because the carcinogens in smoking and alcohol cause the cancer. And we've seen a huge rise in oropharyngeal, that's tonsil and tongue-based cancer. That's one of the most common types of cancer we see in the head and neck clinic, because of a virus called HPV. And I'm sure people have heard of that, and they probably come across it with cervical cancer. And until very recently, teenage girls were given the quadrivalent HPV vaccine. That means there are 100 different subtypes of HPV, but just for 4 of the subtypes that cause cervical cancer and head and neck cancer were covered by this vaccine. Now, remember, this HPV, people think, oh God, how could I possibly get that? Well, put it this way, everybody is exposed. Switch on affect the cell cycle so that it triggers an oropharyngeal cancer. And the surrogate for this virus we call P16. Often you will hear the term P16 positive, P16 negative, and that's just a surrogate to say that this type of cancer is caused by this virus. And it's very important for us, because one, the demographics that Karen's getting at is very different. So it's a much younger age group, often not smokers, often not drinkers. They're healthy young people that happen to get it. And the good news is it has a very good outcome in relative to P16 negative patients. more than 60% plus better prognosis. And the other bit of good news, which I'm really excited about, is that thankfully, in England, the UK at least, they have put out HPV vaccination to teenage boys too. And that's probably the most important thing I will say today, is that make sure your teenage boys are vaccinated for HPV, because Karen and I want to be out of a job in about 15 to 20 years. Much prefer no one having any cancer, at least HPV-related cancer, and that will make us happy chaps and would tie in with our retirement.
Yeah, no, I'm going to say I would agree massively with Vic on that. You know, the one good thing, one of the great things this Conservative government have actually done is to listen to the body of ENT UK surgeons who've started something called Jabs for the Boys, and in 2019 they agreed to expand vaccination not only from teenage girls but to include teenage boys. So I think a big thumbs up to the government on that, pushing vaccination and hopefully having a massive impact, maybe 20, 30 years down the line, but still a massive impact on health outcomes.
Absolutely. A fascinating, really fascinating conversation around this, guys. Thank you very much to you both. And then I suppose one final question then about the overall outlook for patients. I suppose you both touched on it there. For every cancer, it's better to diagnose it as early as possible, at the earliest stage. So what is the general outlook like for patients diagnosed with head and neck cancer?
I mean, it's such a broad question. It's difficult to answer it in one fell swoop. There are different anatomical subtypes, different histological subtypes, different tumor, nodal, and metastatic staging, all that affect outcome. So, an interesting point to take from that. I don't think we can, it's about 700-page textbook to answer that question. But an interesting point to show the importance of early diagnosis is the voice. So the larynx, that's the organ that we speak through, the vocal folds, and the most of laryngeal cancers on the vocal folds, if they get irritated, as we know, after a cough, you get a hoarse voice. If the hoarse voice is persistent, then we worry about cancer. And the good news with laryngeal cancers, this presents early, because people notice a hoarse voice. If I've got a 1 millimeter little thing on my vocal fold, and it's been going on for 6 weeks, I'm going to notice it. If I have a 1 millimeter little lump on my pancreas, I wouldn't have a clue. So laryngeal glottic cancer, particularly, that's the vocal fold cancer, presents early. So glottic cancer has very good outcome. It also has very limited laryngeal lymph spread from the glottis, and that's another reason, but I won't go into it. But the important point is it shows that the early diagnosis, because your symptoms present early, give a better outcome, and that makes sense.
Well, and also going back to the HPV side of things, we said that younger people are turning up with head and neck cancers, but equally they're more likely to be cured. So one of the good things is when it's not associated with smoking and drinking, these sort of tonsillar, tongue-based cancers, our ability to cure them is really improving. We've got advancements in things like transoral robotic surgery. So we're being able to be more accurate in removing them, improving the quality of life. We've also got some really interesting developments in immunotherapy, and that's for people in head and neck cancer currently who we can't give a curative option to, but we can actually often prolong life and improve their quality of life over a longer period of time when we're not talking about cure. So it's interesting where there's so many different developments within head and neck.
I think immunotherapy is it's mind-blowing. Since we started head and neck cancer, the hope that patients can have, at the moment, as Karen says, only for palliation, but people can last many years with what would have been incurable, imminent, death. And I think it will be interesting to see where immunotherapy sits in terms of neoadjuvant therapy in the next 3 to 5 years, as in will we be using it in treatment of curable cancer? If it's crystal ball, I think that's where we may be heading, but there's a space there.
Absolutely. Well, gentlemen, thank you very, very much once again for your time. It was a fascinating outlook and conversation in general on head and neck cancer.
We have a few more moments. If we have a few more moments, is it okay?
Absolutely.
Karen, What do you think? What's the most exciting thing you've seen in head and neck cancer from a perspective of treatment and advancements over the last 5 or 10 years in your consultant life? What do you think?
I'm going to say, I think it's really interesting. It's probably not advancements, but it's a realization of the impact of head and neck cancer. I think that before it was something that people just sort of, they were aware of somebody with a hole in the front of their neck, and there was that one person in the pub who had a hole in their front of the neck, and their quality of life was really affected. But one thing that I've seen is the multidisciplinary approach, that this is a really complex area. Let's be honest. You speak, you breathe, you eat and drink from one area, and anything which is in that area, which is going to change those outcomes, change those factors, can have a huge impact on your feeling of self-worth, how you view yourself, how you view yourself in society. But actually, we've developed things like transoral robotic surgery, transoral laser surgery, which we're able to be much more accurate about what we remove. Before, you used to have to split someone's jaw to go and get a cancer out of their tonsil or their tongue base, and now we're able to do that through the mouth. And rather than being in hospital for 14 days, 21 days, people are often out after 3 days. And their ability
there is that push to doing less to improve and same outcome, higher quality of life, isn't there?
Yeah.
Which is amazing.
What about you? What have you seen which sort of gives you hope for the future, Vic?
I mean, there's so many things we've touched on, haven't we? I mean, I think probably the attitudes towards cancer, it's much more acceptable to talk about it openly. I think that ties in with things like mental health. People are much more open than they used to be. People used to hear the word cancer and sort of go into a shell. But now, I mean, there's lots of interest. I don't know if you've heard of the Nudge Group in the government, but it's this sort of behavioural change that they look into. They did quite a lot of work around COVID, and really, I think our job as head and neck surgeons should be to nudge behavioural change, or as cancer surgeons or doctors, even, or as any just part of society. It's about nudging behavioural change, so it's okay and it's not worrying to go and see a doctor. It's okay to admit that you are worried about cancer and you might not have it. It's not a failing. And I think that behavioral shift happens slowly through cultural endorsements from people like us. And I think that's why these conversations are useful.
I think you're right. I think more people need to talk about what they've got, and be proud of coming through cancer. With, the prediction is that head and neck cancer is going to overtake cervical cancer in terms of overall numbers in the USA by 2030. And I think that will be echoed here in the UK. And that's because of the HPV virus. And I think the same way that there are some amazing proponents for colon cancer, for cervical cancer. A lot of people remember Jane Goody and that increased the number of people going for cervical smears. We need people to sort of come out and speak about these issues, and to actually promote the idea of speaking to a doctor, not being worried, not being scared, and going and being assessed and being part of that 96% who don't have cancer.
Yeah, 100%. Well, 96%.
Well, gentlemen, I mean, absolutely fascinating. It would be interesting to carry on this conversation. Hopefully another day we can do another one like this, because it was fantastic. And again, thank you very much. If there's anything else you'd like to add, maybe for patients to know about head and neck cancer, or do you think that you've covered more or less the topics you wanted to cover this afternoon?
No, I mean, if there are any questions, you can leave them on our YouTube page, and perhaps we can cover them next time. That'll be a useful way to get people to interact. But we've got a plethora of experience between us, and hopefully we can share it and help people out there. Because I tell you what, most importantly, the whole exercise of being a head and neck surgeon is entirely humbling. We do this huge operations on people for 10, 14 hours, and with huge morbidity. However much we think how good we are, any head and neck surgeon in the world is doing a lot of damage to the tissues to get this cancer out. We leave people with that for the rest of their lives, And they, with most, the vast majority of the time, these people are just so brave and get on with things. And it makes you look at your own life and think, really, there's no point, you've got to crack on and be grateful for what we have, but, help each other in some way.
Absolutely, well said, Mr. Dar. Absolutely, it's a real philosophical, a lovely perspective to have as well as a surgeon like yourself with such experience, and I think that will really come across when patients visit you and Mr. Kapoor. I think that's very important to have that. So that's a fantastic way to finish up a really good conversation. Thank you both so much for your time.
Pleasure.